and welcome to the Early Hearing Detection and Intervention EHDI overview for New Jersey Hospital EHDI contacts. This is part 3, which will focus on the quarterly report, interpretation, and use. As with our EHDI for Hospital Contacts parts 1 and 2, the target audience for this presentation is hospital staff that have administrative oversight of newborn hearing screening in New Jersey hospitals. This presentation will focus on the quarterly data reports sent to each hospital by the EHDI program and how hospital EHDI contacts should reconcile and utilize this information. So as with our other parts of this series, again, this is not for the basic screener or other folks that are involved in the EHDI process, but primarily for the hospital contacts that are responsible for quality assurance of the hospital's EHDI program. As you watch this presentation, please feel free to jot down any questions you have that are not answered in this program, and we'll send them to the Department of Health staff when the presentation is over. I'm Kathy Avini from the New Jersey EHDI program. You can contact me, and we will respond to your questions, and also we'll create, maintain, and post a frequently asked questions document to accompany this presentation. Unlike the previous webinars that focused on the administrative code, today's presentation is not about specific mandates you are required to implement, but rather about how we at the state EHDI program try to verify compliance with the rules and also work with you to achieve our shared goals for early diagnosis and intervention for children with hearing loss. So the goals of the quarterly reports that we send out to the hospitals are to monitor hospital compliance with hearing screening and also with the follow-up contact requirements that are in the regs that we discussed in the previous webinars. Also to monitor trends in refer rates and follow-up rates to identify areas for quality improvement, and to allow the opportunity for reconciliation of the hospital's data and the EHDI program data, and the opportunity for quality assurance checks on data entry. The reports are distributed by the EHDI program to usually several people at each hospital. It's our EHDI program's policy that the quarterly report must always go to your hospital's CEO. Had hospitals tell me, hey, the CEO just sticks it in an envelope and throws it on my desk and doesn't really look at it. That's fine, but it's our policy that we want that to at least go by the CEO's eyes and give them the opportunity to know how your program, your newborn hearing screening program, is doing at your hospital. It's fine for just the statistics to go to your CEO, and they don't have to get the data, the detailed reports that we'll talk about, but the reports do go to, are addressed to the CEO and are CC'd to other people in your hospital. The rest of the distribution list besides the CEO is really up to you at the hospital to decide. We have to have at least one person that receives all the detailed reports. Who we are sending the reports to is always listed on the second page of the cover letter in the CCs, and we specify whether you're getting the statistics, or which will say nothing, or if you're receiving all detailed reports, or if you're receiving maybe just the follow-up list, the green sheets that we'll talk about. Also, we have the option of sending the report via email for those people who are receiving just the statistics. And so you'll see all that noted on page 2. And I do ask that you verify that the people on that CC list are getting the correct documents, and that you make any changes to those by notifying us. And also check the titles and the credentials of all those folks that are listed there and let us know. So again, if you're receiving stats only, you can get an email distribution, but if you're going to get the detailed reports, since that's named confidential information, we only send that out via regular mail. So we're going to start by talking about what's in the statistics reports and what you should be looking at. This is what the summary statistics page will look like, and I'll talk more in detail about each of the elements of this page. And let you know that this page is currently generated twice a year. I run it in early February, where it will include data through the 4th quarter of the previous year. We always wait a month after the end of the quarter for follow-up reports to come in on those children. So And the statistics are also run in August, which will include the first 2 quarters of the current year, like you see on this report here. The most recent quarter is always shaded on our reports, as you see in this document here, because we know that children born at the end of the quarter might not have had the opportunity for follow-up yet. So for example, this is a second quarter report, so it would have been run in August. It would include children born through the end of June. So by the first week of August, we're 5 weeks out, and ideally, many of those children will have had some follow-up testing done, but we know that some may still be scheduled in a couple weeks ahead, so we do expect those numbers to change a little bit. We'll talk a little bit more about each of the columns. I'm going to show you part of the screen here. And the first sort of half on the left half of the page is inpatient screening information, and the second half is outpatient screening information. What we would expect you to do with these reports when you receive them, primarily, first off, is to compare yourself to the statewide averages. So you can see that we have the New Jersey totals included at the top of the page, and then your individual hospital's statistics at the bottom of the page. So you can look and say, hey, I'm at 100%, and statewide they're only at 99.8%, so I'm better than average, and know that you're doing well. You also want to look at your current performance and also at trends. Are your refer rates going up? Are they going down? Are your screening and follow-up rates going up or down? It's a good thing to track how you're doing over time, and so we give the previous 3 years as well as the most recent quarters of data. The first column after the description, where it says discharges, is a count, a number of babies that were discharged home. It also includes babies that might be discharged to a long-term care facility. Babies that died while they were in the hospital, or babies that were transferred out of your hospital to another hospital, either in-state or out-of-state, and babies that are still inpatient are not included. So obviously we're not going to hold you accountable for screening babies that are deceased. We don't hold you accountable for babies that were transferred out of your hospitals like we discussed in the previous webinar. And also, if you have babies still hanging out in the nursery and the birth record is not completed yet, so we don't have hearing screening data yet, I'm not including those babies in your count. So this really should be every baby that's gone home from your hospital. The middle section of this report, you'll see says statewide ranges, so it gives the lowest screening rate of all hospitals in New Jersey, the highest screening rate, and then also it gives you the total number of hospitals that are achieving that rate of 100%, which of course is our goal for babies being screened or screened by discharge. And there are currently 54 facilities with maternity services in the state as of the fall of 2013. So we can see that a large majority of hospitals are in fact screening at 100% currently. The back of the summary statistics page contains definitions and explanations for each of the columns. I just have the first sort of part of that page up here. So again, if you get this document and you kind of don't remember what's included or not included in each of the columns, if you just flip it over and read over the back, you can see that information. So again, with the statistics, we want to strive for 100% screened by discharge and settle for 100% screened by discharge or by 1 month of age. And by that I mean if you have maybe your equipment broke or you had a day where your screener called out sick and so you had some babies that were discharged home before screening, since the goal for newborn hearing screening is that babies be screened by 1 month of age, you do sometimes have a little bit of cushion and a little bit of wiggle room there. So if you discharge babies again because of broken equipment, but you manage to get them referred for outpatient screening before they're 1 month of age, then you're still meeting that national and statewide goal, and so it gives you that opportunity to pick up those missing kids. You want to keep an eye on your refer rate trends. If you're noticing increases over time in your refer rate, that could mean that there's trouble with your equipment, that your cables are starting to get old and not functioning as well. On the opposite side, though, we also don't expect or want to see a 0% refer rate. Now, if you have a really small number of babies that deliver during the quarter, it's possible that you would refer no babies. But really over the period of several hundred babies, we really expect to have a baby or two at least that refers. So a 0% refer rate is also a trigger to us that that could mean that there is a problem with the equipment and it's not working correctly. Hospitals that use ABR equipment do have lower refer rates than those using OAE equipment. The average rates by test type is noted on that summary information on the back of the statistics page, so that when you're looking at this, for example, the sample hospital, the refer rates are lower than the statewide average. The sample hospital rates look typical for ABR screening, which is usually around 1%, but since the statewide refer rates do also include babies that refer with OAE, hospitals using OAE, and those have somewhat higher refer rates, the statewide refer rate tends to be higher. So you can flip over the back of the form to see how you're doing compared to equipment method compared to other hospitals in the state. So now we're going to talk about the other side of the summary statistics page, which is the outpatient follow-up information. That first outpatient follow-up column is a count of total babies that need outpatient follow-up. So it includes babies that might have been missed before hospital discharge, and it also includes babies that referred on their inpatient screening. Any outpatient follow-up reported and timely outpatient follow-up reported are the first two columns, percentages in this section. And again, we want to strive for 100%. We do realize that not every baby can always come back for a variety of reasons, and we'll talk a little bit more about that. But we really want to work toward a goal of 100% for those columns. Now, timely means that they passed outpatient screening or had a diagnostic exam with finding of either normal hearing or a diagnosed hearing loss, and that was completed by 3 months of age. So if a baby has an outpatient rescreening, say, and refers that rescreening, and then later they have a diagnostic test, but they're 4 months old by the time that diagnostic testing is done, they would count in your any follow-up column, but they wouldn't count as timely. So for those two columns, again, you want to look at what you're doing on the inpatient side to make sure parents are aware that they need to have follow-up, that you're making sure that the parents know that they need to have follow-up as soon as possible after delivery to try and bring those numbers up. Any child without follow-up completed should have a follow-up attempted by the hospital, and we talked about that during part 2 of this EHDI for Hospital Contacts webinar series. And we're reporting in the percent reported loss to follow-up column the percent of babies that do have that contact effort noted. And so then the final column, which is percent needing follow-up, has the babies that haven't had follow-up and also don't have any documentation of a reminder phone call or other reminder letter, something coming from the hospital to remind the family that they need additional follow-up. So once you make that documentation and that child has actually had a contact attempt made, then they're going to move from the needing follow-up column to the lost to follow-up column. So we want to strive for 0% needing follow-up. And again, I'd like to see all of those babies move into the follow-up reported column and actually into the timely follow-up reported column. But we'll settle for if you have not been able to ensure that that family gets follow-up, you at least need to have documented that they are lost to follow-up. All of these reports will include the previous 3 years of data and previous quarters, either 2 quarters or 4 quarters of the current or previous year. And we do recalculate these rates every time the reports are run. So, for example, in this report, there was a baby born in 2012 that didn't have follow-up done. So the overall follow-up rate for this sample hospital was 95.5%. Now, let's say that baby does show up late in 2013 and has follow-up done. We would recalculate these results when we next ran the report, and that hospital's follow-up rate would then increase from 95.5% to 100%. However, that baby born in 2012 didn't have follow-up until late 2013. Clearly, that wouldn't have been very timely follow-up. So you won't see the timely follow-up column change very much over time, but you may see the other columns change. And as I mentioned earlier, the most recent quarter's data we definitely do expect to change as reports trickle in. And so those we totally expect to change between one report and the next. And even your screening and refer rates may change from the current report to subsequent reports. Remember, I indicated earlier that the statistics for screening include only babies that have been discharged alive from your hospital. So if the baby was still an inpatient in your NICU when the prior quarterly report was run, it would not be included in the statistics until later after the baby's been discharged home. So you will see rates for previous quarters change because of that, and sometimes there are corrections made late to the electronic birth certificate system so that even prior years' information may change by a baby or two along the way. So in addition to that summary statistic page and those statistics, there's another statistics page that comes with your quarterly report that is the JCIH summary statistics. So hopefully you remember from the prior webinars that the Joint Committee on Infant Hearing in their 2007 position statement made several new recommendations about follow-up. And we started measuring compliance with those recommendations shortly thereafter, even though they were just recommendations at that point with respect to our regulations. But in 2011, again, as we addressed in the previous webinar, we did update our EHDI administrative code and made compliance with those outpatient follow-up and inpatient screening requirements mandated. So we've discussed those requirements before, but we'll focus on them again. And the goals for all three of these that are included on the report are 100%. And like on the general summary statistics page, we do compare hospitals' totals to the statewide totals, and we also have statewide ranges. A little bit different on this form. Instead of giving you a number of hospitals that achieve to the 100%, we give you a percent of the hospitals with eligible infants. So for example, the first measure is NICU screening being done using the ABR methodology. Some hospitals don't have NICUs, and therefore that changes the count of hospitals that have infants that need to be screened by this method. So we're just looking at, of all the hospitals that had babies in this category, how many were hitting that 100% requirement. The NICU screening of the NICU babies for greater than 5 days, as we've discussed before, should have ABR screening done, and that's the measure that's the first one on this column. And because that screening is something that's happening in your hospital, that's something that you should have total control over, and we really should see hospitals able to hit that 100% goal. Now the next two columns, and that is that babies that referred on an inpatient ABR are supposed to have an outpatient ABR testing done as well. And the second is that babies that had even a unilateral refer should always have a bilateral rescreening done. Those are reflecting outpatient follow-up. And so we realize that you at the hospital are somewhat limited in your ability to control what happens that may happen outside your doors. If you advise a family that they need ABR testing as an outpatient, and yet they visit a provider that only has OAE screening available and has that done as their methodology, you'll see that reflected in your statistics. And we know that you may not be able to control what's happening in that independent audiology or other practitioner's office. However, we chose to include this outpatient information in your hospital statistics anyway, even though it's not totally in your control, since we do believe that the hospital has an important role in providing parent education. So if you're using inpatient ABR screening, it's very, very important that you advise parents when you tell them the baby did not pass their inpatient screening and they need additional follow-up, you need to be telling them that they need to be scheduling that as an ABR follow-up. Also, if you have physicians in your area that are doing rescreenings in their offices and they're using OAE, yet you're using ABR equipment in the nursery, your hospital needs to be communicating with those physicians, especially if they have admitting privileges at your hospital. You can have your chief of pediatrics talk to them. You can talk about it at pediatric department business meetings. And you need to communicate that since you're using ABR in the nursery, that the required next step is for babies to have an outpatient ABR testing done, so that it's not appropriate in those cases for them to use OAE rescreening in their offices. So we're going to move on. That covers the summary statistic reports. We also create some detail reports. Now, the summary statistics, as I mentioned earlier, are just provided twice a year in February and August. The detail reports, quarterly reports, are what are really quarterly. We do run these 4 times a year. They get sent to the people noted on your distribution that as receiving all reports or these reports. And so these, in addition to February and August with the statistics, they'll come out then, and they also get released in May and November. Since they contain names and birth dates of children, we'll only mail them via regular mail and not send them via email. We will also only mail them to hospital addresses. In general, if there is someone external to your facility, like a contracted vendor, or maybe your chief of pediatrics wants to receive a copy at their office that's off-site, and so you'd like to have the detail report sent anywhere other than your physical hospital mailing address, then your hospital needs to send us at the EHDI program written documentation authorizing us to mail these reports elsewhere, and then we can accommodate that request. Obviously, you should treat these reports as you would any other protected health information. If there are people noted on your distribution list as receiving these detail reports that will not actually be involved in providing services or responding to these reports, please switch their quarterly report distribution status to statistics only. In addition to containing protected health information, the reports are time-consuming for our program to run and to distribute, so the fewer people that we need to send them to, the better. But again, we're happy to send them to anybody at any hospital if they're going to use the data and make use of the data and help make your newborn hearing screening program better. The detail reports include children meeting the criteria that we'll talk about here, that were born within the last 365 days prior to the end of the quarter that ends the statistics information as well. So this allows for reconciliation of cases where babies had long inpatient stays or where the birth certificate system was not finalized and completed for that baby in a timely manner. So cases may extend past the current calendar year. The green reports include babies that are still in need of follow-up documentation. So we think that they needed additional outpatient testing that we discussed in the previous webinar to be completed, and we don't have those yet for those babies. The yellow reports are an effort to help reconcile possible reporting errors, and we'll talk about each of these a little bit more in depth. The green report identifies information on each child, and again, these have been these are samples and have been anonymized so that you see child get the real reports, obviously you'll have the actual child and parent name, information coming from the electronic birth certificate on the child's birth date, the medical record number to help you look up and reconcile these children. So the green reports include both babies that missed inpatient screening and had no follow-up screen documented, and also those that referred on inpatient screening and have had no follow-up. The goal of these detailed reports is for you to reconcile this with your data and your notes and complete any necessary next steps, and then to fax them back to the EHDI program. The due date that you'll see at the top will be 35 days after the day the report was generated, to give you approximately 1 month after you receive it in the mail to reply. The first thing to do is to verify that the babies included on this report really were inpatient misses or refers, as indicated in the inpatient result column. Sometimes there are data entry errors in the electronic birth certificate system, and it may be that the reason that we don't have any follow-up reported for these children is that follow-up wasn't really needed. If that's the case, then first you want to make sure that the information does get corrected in your birth certificate system, and then you would note that in the first checkbox there. So you see on this baby it says screening status not documented, and what that really means is that the fields in the birth certificate for this baby were blank for the inpatient screening test methodology and the screening results. And again, in that situation, that's very often just a data entry error and those fields were inadvertently skipped, and it may be that you just need to correct the birth certificate system. It's also important to keep in mind as you're making any changes that might be electronic birth certificate system errors, that in addition to making the changes, if there are any other parts of the record that are not fully complete, then the record might not get triggered for submission to the Department of Health. So say, in addition to correcting the newborn hearing screening modules, the mother's discharge status isn't filled in yet. So even though you go in and correct the data, it might not get sent off to the EHDI program until the whole EBC record is completed and ready to go. If a baby was in fact missed or referred during their inpatient stay, then this is the time you should go ahead and file a lost to follow-up form to document that you did make your required contact with the parent. We talked about these reports in the past webinar series. Sometimes hospitals are hesitant to label children as lost to follow-up since they're still in contact with the family and hoping that follow-up will happen soon. Please be assured that when we do the statistics in the reports, when we find and use the best of all reports. So if a child has been documented as lost to follow-up but subsequently shows up for some additional testing, it will count as on your reports and in your statistics as that child having had follow-up. It's good to think of the lost to follow-up form just as a way to verify that you made your required follow-up contact, and it's not necessarily indicating that the child is permanently lost to follow-up. There's a comment line where you can document something other than these two options of, oh, this is an EBC error, or, oh, yeah, I did reach out to the family and they are lost to follow-up. So this comment line could be, for an example, let's say you have a baby where you called the parent, so you know follow-up testing was done, and they told you the name of the audiologist's office or facility where that was done. But for whatever reason, that report didn't get to the EHDI program, and that's why that baby is showing up on your list. So if you put a note in the comment line and say, baby seen at ABC Audiology, then when we get your fax back, we in the EHDI program will reach out to that facility and ensure that that report gets submitted to us. The other thing to keep in mind is that there is inevitably some lag time while we run these reports and mail them to you. The footnote at the end of the report will indicate the cutoff dates for the reports. So if you see the report cutoff date was August 2nd or August 7th or whatever it is, and you know from talking to the parent that the baby had a follow-up visit scheduled for October 3rd or August 3rd or August 8th. So you know they probably showed up for follow-up, but probably right after the report was run or the report cutoff date. And so, again, that's the kind of thing that you can note on here. Appointment was scheduled for, and just put the date, and we'll verify that we have received that information. Some quarters, you may not receive this page at all. This ideally would be if all of the patients that needed follow-up had had it, and your follow-up rate was 100%. But also, if you have children that really still haven't received follow-up, but you have already documented that you've made your required follow-up contact by the time this report is run, then there will be no cases listed for you. Another way to say this is that if your needs follow-up column on the statistics page is 0% for the most recent 4 quarters, then you also should expect to have no green sheet. Now we're talking a lot about electronic birth certificate system errors, and this is your opportunity. Say if that baby that says that screening status wasn't documented really was tested and it just wasn't filled in the birth certificate system, and this is your chance to reconcile it. So I want to talk a little bit more about, though, the impact of data entry errors and give you a little scenario here. This is an actual case. You'll see that I've got some detailed information, and I've blocked out references to child and mom and physician names. And you see that this is a baby that was born in July of 2012. They passed both ears in the hospital, but a data entry error was made, so it was in the electronic birth certificate system as a pass in one ear and a refer in the other ear. The quarterly reports were sent out. That quarterly report, since the baby was born in July, would have been for July, August, and September babies, so that report wouldn't have been sent until the beginning of November, since the baby was born at the beginning of that reporting period. And at the time, in November, when the hospital received that quarterly report, they did identify that the child listed on their green sheets was there because it was a data entry error, and they fixed the EBC system and made the correction. So you know, you're thinking, great, fine, all is good. We had an error, we picked it up using the quarterly report, and now it's fixed. So I'd like to talk about what happened between July and November on this baby, and why we would like you to not just rely on your quarterly reports as your sole mechanism for ensuring quality assurance of the data that's reported to the state. We have a process in New Jersey currently where we have used some of our federal EHDI grant funding to hire case managers to do outreach contacts to families and to physicians. Our regulations require that the hospitals make contact to the family, and this is sort of a safety net to help catch any babies that didn't respond to that hospital contact but may be responsive to some additional efforts at contacts and reminding them to show up for care. So in this case, because the child was reported as needing follow-up as an inpatient refer, we had no documentation done. We, again, gave it a little time for the hospital to make that contact and for the family to actually show up to care. But in September, we had no documentation of this baby that we thought referred, so the case was referred to the case managers. And you can see that case manager's documentation efforts here. You can see that first she tried unsuccessfully to reach the mom with the phone number that we gave her, which would have come from the birth certificate system. But so then we also provided a pediatrician phone number. So she called the pediatrician and was able to get a working number for the parent. Now, I do want to point out that this case that I'm showing you represents a number of failures in the ideal EHDI process, not just the incorrect documentation of the hearing screening results in the electronic birth system. Ideally, when the case manager contacted that physician office, the physician should have known that that child's inpatient screening status was a pass. Because if you remember from our prior webinar, one of the responsibilities of the hospital is that you provide the results of the inpatient screening exam to the physician of record in writing. So ideally that pediatrician office taking the call would have checked their record and said, oh, but I show that this baby passed their screening inpatient in July. And we do have cases where that happens. So you'll find that sometimes they reach out to you as a hospital contact and says, hey, our case manager talked to the mom, and they said the baby passed in the hospital, but you reported it as a refer, so why don't you check that and update that for me. Again, another system failure. Case manager called the mom, and mom said, oh, I didn't know my sweet little baby didn't pass their screening. Nobody told me anything. Again, hopefully you remember from the prior webinar that one of the hospital's responsibilities is to notify the parents, both face-to-face and in writing, of the need for follow-up if babies do not pass their inpatient screening. So again, if that had happened, and the mom was clearly educated about the results of the screening, was given the documentation, mom might have been able to say, hey, I have a paper right here that they handed me at the hospital that says my baby passed their inpatient screening. And again, the contact would have ended there and we would have followed up with the hospital to verify that result. But mom didn't have that documentation or wasn't aware of that documentation. So, because the case manager called and was under the belief that the baby didn't pass their testing, mom agreed to schedule a follow-up appointment for her baby. So next couple phone calls are the case manager reaching back to mom to see if she actually showed up for that outpatient follow-up appointment. The next several contacts indicate the mom did make and keep the appointment. And again, we have another different system failure because she went to an ENT office and they should have submitted that follow-up result to the EHDI program, but they did not do that immediately, and it took some phone calls from our program and the case manager to verify that that follow-up had happened and get the report of that follow-up and consider this case closed. So all of that was happening before the hospital received their quarterly report to reconcile this data. So ultimately, because of this one simple data entry error of the result of one ear, that created a phone call to the wrong number, a phone call to the pediatrician office, 5 phone calls to the mother, 2 phone calls to the ENT office. And those things are important because that staff time spent making all those phone calls could have been more productively used pursuing children who really did need follow-up because they didn't pass their hearing screening tests. But that concerns me less than the final thing that this created really was that here's a child that actually did go and have an additional follow-up testing done, which they passed, but that was an unnecessary test. So it was unnecessary travel to that physician office and time and worry about the baby, getting that child to the office, as well as the insurance company or Medicaid or whoever was paying for this exam, paying for a test that was unnecessary. So I bring this case to your attention to say that I really don't want hospitals just waiting until you get to the quarterly report and saying, oh, here's my data entry error. Okay, I fixed it. It's really best if you can do some sort of internal quality assurance process on a more regular basis. Once every couple of weeks, once a month, to just verify what you reported to the state via your birth registration system and what's in your documentation, your logbook, your machine, whatever you have, to verify that what you're reporting to us is consistent with the documentation that you have. This error here is an example of what can happen if you record a baby as a refer when they really pass. We're also going to talk in a little bit about what can happen if you record them as pass and they really referred. These are a few best practices about the process of documenting children as lost to follow-up that I want to go over, because again, the other point of this green sheet report is if they really are lost to follow-up, you did do their contact and they still haven't showed up for additional care, and you can do that documentation when you get your quarterly report. One thing that we've found is that phone calls to the parents tend to be more helpful than reminder letters, because if you actually speak to the parent, if they have had follow-up testing done, or if there's some barrier, they didn't know follow-up testing was needed, you have the opportunity to talk that through. So we do encourage phone calls in addition to or instead of just simply reminder letters. If the parent states that follow-up was done, please ask them where and when. And when you complete the lost to follow-up form, you can put that information. I mentioned you can put it on the comments form if you're doing a fax back of your quarterly report, but you can also, as you make phone calls and you talk to families, complete the lost to follow-up form on paper or in our electronic system and say, the parent said the pediatrician did a rescreen, or the parent said they went to ABC audiology department. The more detail you can give us, a specific name, physician name, practice name, audiologist name, the better, because then our program will track down the report of that outpatient testing from that provider. And even if it's out of state, they went into New York City, they went into Pennsylvania somewhere and had follow-up testing, let us know, because we can often obtain those results. The documentation, as I said, can be done on paper or it can be done in our immunization registry interface. If you want to learn how to use the system, just contact our program and we can set up a training for you. There's a screenshot of what the NJIIS system looks like. This is, again, our test data, and so faked data. You can see that using the system, though, allows you at the hospital to see what outpatient follow-up may have been done. So even if that follow-up was done at an off-site audiology facility, if you don't have audiology services in your hospital, if it was reported to the EHDI program, you will see it in the system, so it will help you know, oh, here's a family that I don't need to do a reminder contact on because they've already shown up for additional follow-up testing. Also, I mentioned earlier that there are follow-up contacts being done by our case management unit staff. And so sometimes when you look, if you look in the NJIIS system interface, you may see, like the case study I gave you, comments from the case managers on contacts that have been made. And you may see, oh, well, the case management unit tried to call the family and found that the phone was disconnected. And you may think, well, so it's done. The baby's lost to follow-up and it's been reported as lost to follow-up. Why do I have to do anything else? A reason for that is because any contact by the case managers does not relieve the hospital of their regulatory obligation of making a contact attempt. So we still need your documentation of contact in addition to any documentation that may be reported by the case managers. It's important also because that verifies that you've looked at and verified the inpatient results were actually reported correctly, and that the documentation that this baby was a referrer and needed additional follow-up wasn't merely a data entry error. The yellow sheets in the quarterly reports were created to reconcile a couple of possible data entry errors that we see somewhat frequently. There's two sections to this report. The first section lists children who are noted as passing inpatient hearing screening. There's their inpatient results, but who also had outpatient follow-up testing done, and that the person doing that testing gave the reason for testing as either referred on a prior screen or baby not screened previously. The green sheets we talked about before help us to capture data entry errors where the inpatient results are recorded as a refer when it was really a pass. This sheet helps to catch the opposite error. As with the green sheets, if there's a data entry error, and the baby really referred inpatient, please correct the data entry error and note it on this sheet before faxing it back to us. There are occasionally situations where a baby really did pass the inpatient screening and then had outpatient follow-up testing, indicating refer on a prior screen because maybe they referred on an outpatient screen and then came back for some additional testing. So there are times that you may verify that the inpatient result really was a pass, in which case you would just check that box and send it back to us. The other time this happens sometimes is when there's some miscommunication and maybe the baby referred on a first test and passed on a second rescreen inpatient, but that wasn't communicated to the parents and they left the hospital thinking that additional follow-up testing was done and they went ahead and received it. So if it was a true inpatient pass, you just need to report that to us. Again, I would stress that you use internal audits or quality assurance checks to verify the accuracy of the reported inpatient screens. Because children are only going to end up on this report if they do have follow-up testing done. For a baby that referred on their inpatient screen but was falsely reported as a pass, if they don't have follow-up done and they're actually lost to follow-up, then we at the Department of Health aren't even looking for follow-up to occur. The cases aren't going to get referred to case management for that additional outreach to the family. And there's a child that is going to be needing follow-up, but the people that might be able to help get that follow-up to happen, their physician program, aren't thinking that we need to make the appropriate referrals for that child. Another comment about the detailed reports and correcting any data entry errors is that this is also going to change your statistics. So that's another reason that your statistics page is going to fluctuate from one report to the next. So for example, in this report there's a couple of babies that did have follow-up. They're not included in the follow-up rate on the statistics page because they're in the system as having passed the inpatient screening and not needing follow-up. So these babies, if the errors are corrected, will increase both the denominators but also the numerators in your statistics on the follow-up, on the summary statistics page. So you'll see some shifts there. The second section on the yellow page lists the children that did not meet the JCIH requirement for ABR testing on NICU babies. Since all hospitals with NICUs have established this now as policy that they routinely do ABRs on their NICU babies, most of the time these are data entry errors, and you can actually see on the sample case here, one error screened with an ABR and the other with an OAE, which is, again, is a very unusual and unlikely situation. So if the method is documented error and needs to be fixed, you can note that. But the other thing that's sometimes wrong is the NICU admission and discharge dates. Maybe the baby wasn't really in the NICU for more than 5 days. Particularly we see this with a baby who might be in the NICU for a couple of days and then transferred to an intermediate nursery, and so the staff only did an OAE screening. But then when entering the NICU admission and discharge dates in the birth certificate system, they reflected the whole stay instead of just the actual NICU days. So it's possible you may need to make a correction to your NICU days. The other thing that does happen sometimes is that babies may actually have been screened with an OAE even though they were in the NICU, again maybe due to miscommunication of how many days that they were in the NICU. And if that's the case, you'll just note that in the final column that indicates that the screening was not in compliance with the rules. So you should be taking these sheets, reconciling them, comparing to the information you have. You have a month to do it from the time you get it. The fax number to send it back to us is always at the top of the form, and we give you a due by date. And then I do check that all of those reports have come in, that all of the EBC system errors have been corrected, that all of the missing lost to follow-up reports have been received, and hopefully that all of the information and cases have been reconciled. Again, if you ever have questions about the quarterly reports or about any other aspect of our EHDI program, you're always welcome to call us. You can contact us at our main EHDI email address or any of our individual staff email addresses, or contact us by phone. I would also strongly encourage you to give me feedback on the quarterly reports. If they're confusing to you, if there's a better way to present the data, if there are statistics that don't make sense to you, if you're really sure you are at 100% but I'm only showing that you're 99%, give me a call and we can talk about it and we can review what specific cases are keeping you from achieving your goals. So again, I thank you for joining me today. This concludes our whole webinar series of EHDI for hospital contacts. And we hope to continue to work with you, and we hope the information in these webinars has been helpful to you in order to successfully run your programs and meet your goals and our goals. Thank you.